a case report regarding how to deal with heart failure in a patient 1 year after TAVR, considering that this patient has a long history of coronary artery disease. So, this is a 70-year-old gentleman presenting at the emergency with NYHA class 3 1 year after TAVR. The medical history is following. He has heavy risk factors, hypertension, type 2 diabetes, overweight, 103 kilograms or 178 centimeters, and a smoker, active smoker. He has a severe coronary artery disease starting from 1995 with stenting in the coronary artery, right coronary artery, the distal coronary artery, the LAD proximal, and then against the coronary artery, right coronary artery proximal, and then the middle LAD. And in September, he got a thallium positive with infero-septo-apical plus antero-basal ischemia. He has a previous atrial fibrillation, IHS blade 5, and he got an occluder in 2018. And he has also a terminal renal failure with a clearance of creatinine of 18 millimeter per minute. And obviously, he has also a severe aortic stenosis who got TAVR in 2020. And after TAVR, he was equipped with a Micra pacemaker, which is a pacemaker without a wire. So, at the first hospitalization, we treated first with furosemide IV with increasing doses going from 100 milligrams to 1 gram. And the ejection fraction, who was 55 after TAVI, was going to 45. The core valve was functioning very clearly. There was no gradient, there was no dysfunction, no aortic failure. So we performed a coronary angiogram, and we were very limited because of terminal renal failure and by also the core valve. And so as you will see, the picture were really suboptimal. You can see here the right coronary artery, left coronary artery, and in fact, we could consider that this shows a TIMI-3 in the circumflex and the left main and the LAD, and then we went to the right coronary artery, and basically, again, we could see the right coronary with the two terminal branches with a TIMI flow, and we considered that, in fact, this was more or less okay for him and for his renal failure. The patient went out of the hospital a little improved by a lot of furosemide. And then 1 week after, he came back with a global heart failure, chest pain, and troponin elevation. And the ejection fraction was even less, from 45 to 40%. And then we decided to go to the coronary angiogram based on the chest pain, on the troponin elevation, and on the very suboptimal first coronary angiogram. And the goal was to obtain satisfactory evaluation of the coronary artery to eliminate or to treat an ischemia, which was, by the way, already shown by the thallium. There was so no more concern with the terminal renal failure. Just this slide to show the complexity of coronary angiogram after TAVR, going with different valves. You have the portico on the right, the Medtronic in the middle, and the sapient valve on the left. And so this number shows, in fact, the success rates of angiogram and PCI after TAVR. And it seems that, in fact, the Medtronic valves have an 84% successful coronary angiogram going down regarding the right coronary artery. And the PCI was a success in 69% only, because, in fact, it was not really selective. So for the Edward valve, the coronary angiogram was around 94% and the PCI was 94%. So what we did is the following. We tried to, with the guiding catheter, to be in the direction of the right coronary ostium. And then I catheterize with the guide wire, simply BMW guide wire, to enter and to penetrate into the right coronary artery. And this was, in fact, not that difficult. Having done that, the second principle was to insert a guide liner over the wire into the RCA. And in fact, this was also very not very easy, but feasible. You can see here the wire, and here you see the tip of the guide liner. And here you can see that the right coronary guiding catheter is still outside. So the goal is not to put the guiding catheter inside through the struts of the prosthesis, but to use the guide liner, which is much easy to use. And so the next step was to identify and to make a selective angiogram through the guide liner. And as you can see now, I start again. Now we can definitely identify a first lesion on the top, and then the middle, and then on the distal coronary artery, we can see the three sites to be clearly treated, and which explain the situation. Here you can see that we were able to introduce easily through the guide liner, 5 French, the balloon and then the stents in order to treat the 3 sites of stenosis of the coronary artery. And here you can see the final result, which is clearly selective made by the guide liner. And we see that our guiding catheter is still outside the ostium of the coronary artery. Let's go now to the left. So for the left, the same thing. We position the guide wire, the guiding catheter in the direction of the ostium. And when we are really very close in terms of selectivity, we try to insert the wire through the struts of the core valve, and then we go inside the LAD, and then we insert on it the guide liner. And so this allows us to perform, as you can see, a clear angiogram, and we can see that even if the TIMI is free, the TIMI flow is free, there is at least one severe stenosis in the middle LAD between the 2 stents. And so, in fact, as I told before with the RCA, we were able, via the guide liner, to introduce the stent and to treat correctly the artery. And then this is the final result. And so now we are sure that the situation is fixed in terms of coronary artery. So the evolution was very clear. Stop dobutamine after 24 hours, reduction of furosemide from 1 gram to 160 milligrams in 72 hours, clinical improvement of right and left heart failure in 48 hours, early improvement of the ejection fraction at day 3, going from 40 to 51% ejection fraction, and then back home at 4 days after standing, NYHA2, and clearance of creatinine, which was not really decreased by the coronary angiogram, and the PCI went from 18 to 24, which was also a progress. So let's look at the data from Mentias, who showed that outcome of unstable angina, ST minus and ST plus post-TAVI. And we can see that the acute coronary syndrome ST minus or ST plus are having the same outcome in terms of survival, which is clearly different from the simple unstable angina without elevation of troponin, which means that we have to intervene. So if we look at now the same study from Mentias and the JAC, looking at conservative strategy versus invasive, we clearly see that in survival probability, there is a clear, significant difference at the credit of the invasive strategy. If we look at the distribution of MI type by time of presentation, we can see that, in fact, mainly this present as a ST minus for 85% and 15% for ST plus myocardial infarction. And this is quite regular within from less than 7 days to more than 6 months. And so in this meta-analysis from Mentias, it's clear that the advantages is to the intervention compared to the conservative. And the conservative approach is based on the acute injury, the female age, the people requiring blood transfusion, the underweight, and why people would be very aggressive, because it's a presentation with cardiogenic shock, because there was a prior revascularization, before it was a late ACS, more than 6 months, and before it was a STEMI versus unstable angina. So if we look at the difference between 1 year mortality between the conservative 44% versus 29% for the invasive strategy, the same at 30 days, 17% versus 8.8% for the invasive strategy, and one in-hospital mortality, 8.4 for the conservative versus 4.8. So you get credit very early, as I showed you in my case presentation. So the better, the sooner the better, and the more invasive the better. So the delayed coronary occlusion after TAVI, basically it is valve-in-valve is a great risk factor. Regarding the valve, it seems that the self-expandable have more risk of delayed coronary occlusion than the balloon expandable. Regarding the timing from Jabour, we can see that, in fact, there is during the first year, there is clearly still cases of acute coronary syndromes, but there is still, in fact, late coronary syndromes in these patients. So the identified feature of unfavorable access after TAVR, I have no time for looking at that, but this is very important to know by CT to identify whether you have a favorable or unfavorable coronary access, whether the coronary ostium is below the skirt or in front of the THV commissural posts. So again, it's very important to check by a CT scan the before and after the different criteria, which is the length between the annulus and the ostia. Second, the distance between the ostia and the valve. And when this space is less than 2 millimeters, this is an unfavorable risk of unfavorable coronary access. Okay, this slide from Abdel Ghani, it's a very nice place to show that, in fact, you have different situations, closest aligned cell, interference by the commissure, and so on. So, in conclusion, the management after TAVR, we should perform our best to be able not only to look at the coronary arteries selectively, clearly, and to be able to perform a stenting if necessary, because the mortality is 100% higher in case of conservative strategy. And the little plus that we propose is this concept of not being selective with the guiding catheter, but getting via the guiding wire inside the coronary artery, and then being able to selectively insert the guideliner system or any other system from the coronary guiding catheter inside the coronary artery. So, in conclusion, coronary catheterization may be challenging after TAVR. Outcome clearly better if acute coronary syndrome treated by PCI. Coronary access may be facilitated by wiring the coronary artery, access to the coronary artery guideliner, and third, easy access for performing selective coronary angiogram and then stenting. Thank you very much.